All right, we're just welcoming everyone to the webinar. We'll just wait a minute or so to let people log on. Exciting webinar on medical cannabis and its use in chronic pain with Dr. Phil Finch and Dr. Matty Moore. We'll just wait another minute or so for everyone to join. All right, we might get started. My name is Barb Fullerton. I am the head of education here at Little Green Pharma, and I'm excited to welcome all of you to the webinar, A New Perspective, and looking at medical cannabis in chronic pain. We have two very experienced medical cannabis prescribers with us tonight. Dr. Phil Finch, anaesthetist and pain specialist, who's been working in private practice or in the field of pain medicine since 1978. He's the medical director of the Perth Pain Management Centre here in WA. And as I said, has been prescribing medicinal cannabis pretty much since it became legalized here in Australia. And he's excited to share his knowledge from a pain specialist perspective and how that's impacted the way that he treats patients. And then Dr. Matty Moore is a GP specialist in Dunsborough, who was looking for alternative treatments for different conditions, including chronic pain. And got frustrated by the medicines that he was using. He's now considered one of the leaders in the medical cannabis space across Australia, and also has his own clinic, Mode, which has locations in WA, Victoria, and is spreading rapidly because it has a telehealth capacity. So welcome, Phil, sitting next to me who you can't see, but you will be able to see shortly, and Matty. Now, I am just going to look at what we're going to cover tonight. So I will give you a quick overview of medicinal cannabis, looking at things like toxicity and dependence risk and where it's being used at the moment in Australia. Phil will run through his experience in prescribing cannabinoids, addressing the statement that was brought out by the Pain Society of Australia and New Zealand, because that is very interesting and has impacted the way a lot of pain specialists are practicing. He'll also review the literature and data from available and how that translates into his current pain practice. And he also has a couple of case studies, which he'll share. Dr. Matty Moore will look at managing chronic pain in general practice and some of the trends that are happening in that space as it relates to medical cannabis. And we'll also address some of the concerns and also cover some case studies. We will also have a opportunity to have questions at the end. So as we go through the webinar, feel free to pop a question in the chat function, which you'll be able to find on the webinar there. And just so everyone who's not presenting knows, your cameras are off and you're muted. So and that will stay like that the whole presentation. So feel free to go about if you're doing something else at the same time, that's absolutely fine. All right. So before we get started, we'd love to know how many of you are already prescribing medicinal cannabis, as well as your level of familiarity with medical cannabis. So if you're interested but not prescribing yet, if you've written a few scripts, or maybe you are already a regular prescriber, that gives us a good idea. Okay, I'll give it a couple seconds here. Jumping back and forth, it's quite interesting. I don't know if you can see the poll, Matty, but I
can.
Okay, yeah. So of those that are on the webinar, a slight majority are not yet prescribing. About just over 40% are already prescribing. Of those, in terms of their level of familiarity with medicinal cannabis, most of them, about 50%, are interested in prescribing but haven't done so yet. So this will give you at least some insights and some, I guess, practical examples of how it's being used. There's about 10% that have written a few scripts and about 40% that are regular medical cannabis prescribers. So quite a nice range there, which is good. Awesome. So without further ado, I'll quickly talk about cannabis and its use in general. So cannabis was part of, I guess, the way that humanity practiced medicine from the beginning of time, and it was quite normal. When I first got into cannabis about 5 years ago, I was new to it altogether, and I knew nothing about it. I was curious to understand, prior to it being made illegal, how much of it was available at the beginning of the 1900s. And I counted about 130 different cannabis products, and there are two examples of those shown here. So companies like Park Davis, which is now owned by Pfizer, they regularly produce these products, and they were available and pretty much in every medical practitioner's bag back in the day. And then what happened was, just purely due to political reasons, it was added to the UN Convention on Narcotics, and it was listed as a dangerous substance, which we'll go through in this webinar and show you that it's actually not. And now it's coming back into, not necessarily back into fashion, but being used much more regularly in the day-to-day. And it's really interesting to see how Phil, from a pain specialist perspective, as well as Matty from a general practice perspective, have really incorporated that into their practice. So looking at, before we go into where we're up to in terms of its usage, it's important for everyone to understand that we all have an endocannabinoid system. It's found in every single one of us. It's not something that was discovered till the 1990s. So the endocannabinoid system is actually responsible for the different body functions and regulating those. So things like pain, your sleep-wake cycle, appetite, digestion, your mood, are all influenced and regulated by the endocannabinoid system. It's really responsible for creating homeostasis within your body. And you've got CB1 and CB2 receptors that are found all throughout the body, including in your brain, your immune system, lungs, liver, spleen, pretty much everywhere. And interestingly, CB1 receptors are one of the most common receptors in the brain, which is actually a fact that probably most psychiatrists are not aware of. But one of the things I found really interesting since this space has emerged in Australia is when we get patients calling us, they might be taking it for pain, but they found that they're sleeping better, their mood improves, and they're able to lose weight. They're not focused on eating so much. So it tends to have a more holistic effect as opposed to your traditional pharmaceutical product, which is one molecule designed for one side effect, for lack of a better explanation. So it is a really interesting way in which it works. And interestingly, your body actually produces its own endogenous cannabinoids. So your body's version of THC is an anandamide, and that's responsible, for example, for after you exercise or go for a run and you feel really good, that rush you feel is actually an anandamide. So it's quite interesting how this is really incorporated into our bodies already. Now, how do THC and CBD compare in the treatment of pain? Another really interesting thing is they both can be analgesic. I would say typically THC is more analgesic. Again, they can both be most anti-inflammatory, CBD typically more so. Both can be anticonvulsive, antiemetic, and help with sleep as well. I personally take CBD for sleep and find it really, really good for that bouncy brain I get when I'm trying to fall asleep, and helps me stay asleep. They can also both be neuroprotective, help with appetite stimulation. CBD, interestingly, also reduces the intoxicating effects of THC. So that's why they're often used in combination, particularly in oil products. So when you have THC combined with CBD, patients are less likely to feel high or intoxicated if they're using a THC dominant product or THC on its own. CBD has also been really effective in helping with people who feel anxious, and can also be used to help with people who are also depressed, and can help with improved cognition. Another stat that's quite interesting is the TGA publishes, from a SASB perspective, what conditions are being prescribed, what patients are being prescribed cannabis for what conditions. And through COVID, anxiety was the second biggest indication for which cannabis was prescribed, which I found interesting. But before that, it was probably the fifth or sixth down the line. In terms of the toxicity of cannabis, this is another misnomer. This is looking at acute lethal toxicity of different psychoactive substances. So if we take alcohol for as an example, it has a 1 to 10 ratio. So if I have 4 drinks, I'm probably feeling pretty happy. If I have 40 drinks, I'm probably going to die. So that's the lethal toxicity. If we look at cannabis, it's 1 to 20,000. So it's physically impossible to die or to overdose on cannabis. There's actually no CB1 or CB2 receptors found in the brainstem. So unlike things like opioids, etc. Another interesting thing about cannabis is the dependence risk, which I think is often misunderstood or misconstrued in the public. So if we look at the dependence risk of cannabis as opposed to, say, alcohol or caffeine, alcohol has a dependence risk of 1.6, whereas cannabis is actually half of that. It's 0.8, which is less than caffeine. So overall, and this study is looking at more likely street cannabis, which is higher in THC. So when you combine a product that has THC and CBD, it would again probably be lower. So again, a common misunderstanding is the risk of dependence with cannabis, but it is relatively low as compared to other products that are out there. So I'm just moving on the screen. Now, in terms of the most common indications in Australia, as I alluded to before, most common is still chronic pain by a country mile. It's about 60% of most common. This is based on the SASB data available through the TGA's website, followed by anxiety now. So that used to be third or fourth. And sleep is now the second, whereas it used to be palliative care and cancer pain symptom management. So it's really interesting to see how those different indications have moved over the last few years with the impact of COVID and other external factors. So, but by and large, you're in the right place if you're looking at using cannabis and haven't before in your practice, because pain is one of the most common areas where it's being used. In terms of, I guess, the trends around cannabis, so up until around 2020, a couple years ago, the main types of products that were being prescribed were oils. So it was around 42,000 approvals for oil products in 2020. In 2021, flower was introduced to the market. At that same time, there was a relaxing of, I guess, the ways that the state and TGA were overseeing cannabis, because at that point they had enough data to make a call that it was fairly safe and there were minimal adverse events. So they relaxed their limits on prescribing. So there was kind of a perfect storm there. So what we saw in 2021 is oil typed medical cannabis products with different ratios of THC and CBD were still the most dominantly prescribed, but flower products, so the flower that your next door neighbor might grow in his backyard illicitly, is now the second most prescribed. And Matty will talk you through that in his practice, which has been a really interesting evolution again of what he's doing as a prescriber. And in 2022, you'll see this number drop down. This is a full year's worth of data in 2021. This is not a full year, but you're also seeing a lot of practitioners moving from the SASB perspective over to becoming authorized prescribers, which is a different data set that's not combined here. So that's why you see that drop. But the growth of cannabis is still exponential in terms of its prescribing. Without further ado, I'm going to slide this over to Phil Finch, who's going to talk through his experience.
Thank you very much, Bob. Yes, welcome. First of all, I just will show you my disclosures. I hold some shares in different companies involved in cannabis. Some of them are not doing very well at the moment in the stock market. Ozcan, for example, is moved into veterinary cannabinoids, but an interesting area. So,
Thanks, Phil.
yes, thanks. Yeah. So the story of why I got into this, I was aware of the federal legislation coming along in I think it was about 2018, 2017, and I became interested in cannabis, as at that time I was ceasing to work in the operating theatre. Before that, you classed me as an interventionalist in chronic pain, doing various procedures, and I stopped that mainly because of my age. And I became interested in cannabis, so I moved into that, and I prescribed various forms of this agent for 521 patients. Now, this doesn't sound very many, really, compared to some of the Matty and others. The Emerald Clinic, for example, has maybe 7,000, I think. But the way I practice is slightly different in that I can offer all other forms of chronic pain management. So my involvement is not a monotherapy. I've noticed cost is quite an issue for for the pensioners and many patients, but fortunately it's a competitive market and matters are improving from our point of view. I've adopted a very simple approach to prescribing using only a limited number of companies and types of cannabis. I'll describe that a bit later. We're now often starting with pure CBD as due to the driving law issues, which I'll touch on. At the moment, we're almost completed enrolling patients in a registered trial into the effects of medicinal cannabis, because anecdotally, a lot of them reduce or cease taking opioids, which is a very useful attribute. This will be closed off at the end of this year, and we'll start looking at the figures after 1 year total and more. So the number of patients I've prescribed is 521, mostly a mix of THC and CBD. I started trying CBD in the last year due to my colleagues found considerable success in using this and due to the driving laws. So I've got a number that have been really positively improved by CBD only at 17, which is quite a small number, but this will increase as I've often started prescribing CBD only without its euphoriant effects and the issues of driving. I've often started that with people, especially younger people or people that have to drive. I looked at the number of diagnostic categories. Unfortunately, I started off not really intending to keep these figures, but I know from the forms that I send into the health department, we have to put a diagnosis. And these are some of the figures that by far the commonest has been spine pain. Cancer pain is another group that I'm increasingly prescribing to. Neuropathic pain from various nerve injuries are another group. So these are the group down to fairly small numbers of post-herpetic neuralgia and peripheral neuralgia. I've also kept some figures on the number of patients who have actually stopped taking it. Now, there are a number of reasons which I'll quickly go through, but the total came to about 48%, which seems an awful lot of patients gave it up. But this is from the time I started over several years. And interestingly, spine pain is quite largely represented in this group. So also you could think of it, if 47.8 of total prescribed have given it away, 52% approximately are still using it, which suggests some success in some form, such as sleep or pain relief. So just looking quickly at these figures, the lack of effect is one of the commonest reasons to give it up. Adverse effects such as drowsiness or some of the other well-known side effects, and another group. Unknown reasons is quite high. Vehicle driving worries, some people are worried about, and I'll touch on that. In pain has been improved in a very small number, following surgery and small number due to work issues, some of being in a FIFO state. The patients, the patients are moving in and out, and they're going onto mine sites, and they're not allowed any THC, and so there are worries there. The cost is another reason, and some pregnancy and decease. I'm seeing an increasing number of cancer patients, and of course they pass on. I will talk briefly about the Faculty of Pain Medicine, who directed a poll to the fellowship about whether they should support choosing wisely recommendation for cannabis, and they were of the opinion that it shouldn't be prescribed until more data is available, or more studies have been performed. I think there have been a huge number of studies, something like 400 trials. So I'm not going to really go into that. Anyway, the ANSCA, my college recommendation is that you should not prescribe currently available medical cannabis products to treat chronic non-cancer pain unless it's part of a registered clinical trial. So quite a few of mine are in a registered clinical trial, so I am prescribing it. And I found it extremely useful and a wonderful pharmaceutical. So my view, very quickly, is that it's extremely safe pharmaceutical with a very long history, 10,000 years to the beginning of the written word. It does not suppress respiration because of the site of the cannabinoid receptors. There are very few in the brainstem. There are no worrying features seen to date except the vehicle driving laws. It's vastly preferable to many of the drugs that are prescribed for chronic pain, including opioids, antidepressants, and pregabalin, which I spent a lot of time taking people off pregabalin due to the colossal side effects that people experience on this anticonvulsant. It can be tightly controlled, and I scrub out the bit of the co-prescriber on the approval form for the WA Health Department so that I'm the only prescriber, so the patients can't get it from anywhere else. I keep a very close track on how much they're on, and there are controlled amounts that they're allowed per day. So it's tightly controlled. Although it's a fairly weak analgesic drug, it often improves patients' well-being. They sleep better, they reduce their opioids very considerably, and anecdotally, this is about 30% of reduction in opioids, especially patients on high amounts. And this is the study that I'm looking into with two parallel practices. So hopefully I'll give you some data in a year or so. The cannabis abuse disorder seems to be rare, and I really haven't seen the issues of addiction. Does not have the problems that opioids have. There's some literature on opioid reduction. I won't go into all of it. Some of it helpful. A reduction seen in patients on higher doses of opioids in a study by Lee et al. 2021. And I think this is probably the findings of my colleagues elsewhere. There is an American study reference there that showed the vast majority of trainees in medicine don't know very much about medical marijuana, and they're not prepared to prescribe it or answer questions about it. Seems a pity, because I think this is a wonderful pharmaceutical. There is a pronouncement by Henderson et al. This is an Australian study in the Australian Journal of General Practice. There is clearly a disconnection between the pronouncement of specialist medical colleges and current prescribing community use of cannabinoids in Australia. We hope in the future this will be rectified. An excellent review is in the paper by McCallum and Russo in 2018, and I would recommend that you read this. It gives the practical considerations of medical cannabis administration and dosing. It's a wonderful paper. vehicle driving issue is set out here. I get patients to sign this once they've read it. They don't sign it in front of me. They go home and read this. But I'll just read it. Cannabis is a legal drug in Western Australia that can be prescribed by any medical practitioner with the necessary state and Commonwealth approvals. It is illegal to have traces of THC in your system, which is of course a component of cannabis. And the way it's metabolized is that THC goes from absorption into fat depots and then gets re-released into the vascular system. So if you've got a very sensitive device for testing it, you could test it later. You could pick it up weeks later. Traces of THC can be detected with very sensitive equipment for several days or weeks afterwards. It is unlikely that a roadside mouth swab will test positive by the approximately 12 hours after. And so you need a blood test to pick it up. Not only could this incur legal and criminal penalties, it could incur civil penalties if you are in a major accident with a loss of insurance. So people that don't want any risks are best to start and stay on CBD only. So it's suggested that the only way to be sure that the above situations do not arise is not to drive a vehicle when you've been treated with medicinal cannabis in the previous week. And actually the Premier of our state, West Australia, I have a letter to a patient saying that his advice from the police is that people shouldn't take it for 24 hours, I think it was. I'll just give you two case studies briefly. This about how we're going for time, Bob. All right.
Speed it up.
Speed it up. Okay, very quickly. This is an 84-year-old male, and he had low back and pain and sciatica, which is a common thing on various drugs. Antrolithesis, L5 on S1. So I've looked at him, I've examined him, and started him on a balanced medicinal cannabis. That's 10 milligrams of each of the components with a good response, but he developed diarrhea. And so I consulted my colleagues in this city, and they suggested kindly that if I was to change the ratios, reduce the CBD and increase the THC, there would be improvement. In fact, that's what I did. I put him onto a 20-5 mixture, and his diarrhea settled, and he had excellent analgesia. So that was a success. And the other case study is a retired bus driver who had 2 lumbar surgeries, typical spine ones that I see with limb sensory changes, neuropathic sensory changes, and on opioid drugs, tapentadol, 200 milligrams a day, and codeine. Anyway, so the justification was increased low back symptoms with surgery, not a realistic option. And again, I started him on 10-10, as my approach has always been very simple and straightforward. Start low and stay low if you can. Good analgesic response, and he was reducing his opioids with the cessation of codeine and a reduction in the tapentadol. So that concludes my bit, and I'll pass it over to the real expert, Matty Moore in Busselton.
Oh, thanks, Phil. Thanks, Barb. Great to be with you guys. Get the dream team back together again. I love it. Well, look, I'm Matty Moore. I'm a general practitioner, chief medical officer, and co-founder of Mode Healthcare, which is a holistic clinic down in Dunsborough. And I've been an authorized prescriber for several years. Started trickling patients initially, and found such great success with that extra tool in my toolbox that it was almost exclusively what we started doing. So I've got no disclosures, no stocks, no agreements, no products that Mode itself makes. So completely non-biased and product agnostic. Sorry, guys. There we go. So look, I mean, many of our patients as GPs are chronic pain patients. I mean, I see multiple patients every day with chronic pain. And so, you know, really my approach is teasing out exactly what type of pain they have, first of all. If they're undifferentiated, you know, we do imaging, we do ultrasound, you know, we do blood tests and see and figure out which of these indications, the subset of indications in chronic pain that these patients are suffering from. And then most of these are you know, refractory chronic pain due to either osteoarthritis, neuropathic origins, autoimmune, you know, fibromyalgia, IBS, migraine disorder, which is thought to be a deficiency in the endocannabinoid system. And then, you know, my typical protocol for treatment is obviously each indication, you know, starting at a different type of ratio of cannabis oil. I always start with oil first because that's best for chronic conditions due to its, you know, pharmacokinetics of long action, long duration of action, rather, up to, you know, 8 to 10 hours. So that's dosed multiple times a day. And really, you know, for instance, with osteoarthritis, which is an inflammatory condition, you know, I always start off with a CBD majority oil, slowly titrating it up from small amounts and encouraging my patients to be mindful with each increase so that they're paying attention to their symptoms and using as little as possible for the greatest benefit. You know, there are some significant neuropathic pains, you know, patients also on large doses of opiates for long periods of time, which do require better analgesia with THC. And most of the time I start off with a balanced full spectrum oil and work my way up from there. You know, sometimes patients will require other forms of medicinal cannabis for that acute type pain, and I'll go over that here later on. So some common concerns, a lot of the statistics, the SASB, as you've heard earlier, you know, there's a great percentage of, you know, flower patients now, and that shouldn't be alarming, to be honest, because, you know, you realize that this chronic pain is significant. These patients have found cannabis to be helpful themselves and are accessing this medicine on the black market. So the fact that patients are showing up with cannabis in their history isn't surprising and isn't alarming for me, because it gives me an opportunity to really manage this in an appropriate way, in a mindful way, and show our patients that they're probably using too much, and changing a patient from the recreational market to a medicinal market is a real opportunity to teach patients and educate them on the proper forms and proper use of cannabis. Yeah, these demographics, as Barb stated earlier, are changing quite a bit. You know, most of my patients initially were honestly over 60, were conservative, had never accessed cannabis before, and were really kind of at their end of their tether. Now, since, you know, there's better access, more and more GPs are prescribing, there's more clinics prescribing, so that skews the data a bit in flower. And, you know, like I said, there's a lot of patients that are already accessing medicinal cannabis on the black market that prefer flower. I always start oil first, no matter what, because, you know, I think that's really a stipulation, number one, that my state health department prefers. And also I think it's safe because it reduces, you know, tolerance, and it reduces abuse. So like I said, current trends, you know, are changing a bit. You know, like we typically would start with one type of oil. If that doesn't work with a particular ratio, we move that up to a stronger ratio or down to a less strong ratio with THC. Sometimes conditions really do, if you start, you know, thinking initially, gosh, this patient has significant pain, they're probably going to need THC. Sometimes they don't. Sometimes they do much better with CBD majority oil. Why that is? It's very different for each patient. Each patient has a different endocannabinoid system, you know, different liver function, different exposures, different other medications coming through the P450 system. So there's lots of variables to consider. So, you know, introducing additional products after one product doesn't work or one ratio doesn't work. And like Phil said, a lot of the times we use CBD majority oil during the day to reduce risk for patients who are driving and who are working. And then increasing the THC content at night sometimes, splitting that regimen, patients can get really a much more restful sleep, control their pain, and the trickle down on that the next day is reduction in anxiety. That the triple whammy, a lot of patients have chronic pain and have comorbid mental health disorders along with a disturbance in sleep. And therefore, one medication can reduce polypharmacy and treat multiple conditions. And that's a no-brainer for me. It makes perfect sense. So moving on, if patients aren't getting benefit from a split regimen, many times chronic pain, there's an acute exacerbation of that. And, patients are taking their oil, but having to wait for that to be active in their bloodstream. And we'll go over this here in a minute with some graphs on the pharmacokinetics. So why use vaporization as a form of administration? Well, just that. I mean, the oils take a while to start working, and therefore there's a window where their pain potentially is untreated. And that's where flower can be very helpful. Don't be intimidated. It can be a real opportunity to teach patients to do the right thing. Smoking obviously is much more harmful for the lungs and cardiovascular system. We always encourage patients to use a vaporizer unit, and that reduces the tars, the toxins, and their carcinogens. And I don't usually, like I said earlier, start cannabis flower as a sole therapy or the first therapy. It's always with oil, and then the flower is an adjunct to that. There are a vast minority of my patients that are only using flower. And we use flower because of its quick onset of action when treating conditions such as breakthrough pain, insomnia, PTSD, panic attacks, and anxiety. So this is the graph that I referred to earlier, the THC concentration on one axis and the hours or time on the next axis. And you can see that in the green is your cannabis oil, which takes anywhere from 1 to 3 hours to start working. We always encourage our patients to place the oil under their tongue due to that high absorption rate of the vasculature there. And that will allow the medicine to start working and achieve symptom relief much quicker. But still you're waiting, definitely, because of the medicine, when ingested, goes down the esophagus, into the stomach, through the small intestine, uptake into the liver, and then metabolized. And that takes time. So therefore, your patient's pain is potentially not treated, and there is where the benefit of flower is. You can see that it's almost an immediate response, and it lasts for about 2 to 3 hours, that window where the oil is ramping up. So I've got a couple of patient case studies as well, and both are middle-aged men with abdominal pain. The first is a 43-year-old gentleman who had some significant abdominal pain due to bilateral inguinal hernia repair that didn't go so well. And a couple of years later, he had a revision of those hernia repairs. I believe he probably had some nerve entrapment and muscular spasms because of that, and really was not doing very well. He was on high doses of opiates, Lyrica, and benzodiazepines. And those symptoms, chronic abdominal pain, numerous side effects from his medications, as Phil stated, Lyrica is one of those that can be helpful, but at what cost? He began to be very withdrawn, depressed, and starting to have relationship difficulties with his family. His medications when I met him were diazepam 5 milligrams 3 times a day, endone 5 milligrams TDS, as well as Lyrica 150 twice a day. And these treatments had not controlled his symptoms, and he had side effects. So that's where he, was able to access medicinal cannabis. So we commenced him on a 10 and 10 oil 3 times a day. We titrated it up slowly with effect for about a month, reviewed and noted that he was still having some significant pain overnight. So we then titrated him onto a 20 and 5 at nighttime, reduced that CBD content for the nighttime so that THC did really help him sleep and control his pain. And he was on that stable dose since December 2019. As stated, the balanced oil was initiated 1 ml twice a day, and then a 0.5 ml of the 20 and 5. And then as an authorized prescriber, we're able to use 40 milligrams of THC in a liquid form a day. That's our maximum. So patient reported that his pain was considerably less. His mood was much improved. He, discontinued all his opiates and benzodiazepines, which I think is an incredibly valuable thing. Patients are very happy with that. They're proud of themselves. They feel so much better without all those side effects. He started going to physiotherapy, and he and then started to be a much better father, husband, and got back to the job market. So my second case study is also a 41-year-old gentleman with abdominal pain. He was miserable. He had a history of diverticulitis with a perforation. He had a stoma and a colostomy placed. He then had 4 separate surgeries for herniation in and around that stoma. And he had prior relief with cannabis, but when I met him, he was not currently using. So he had a family history of diverticular disease. He was a smoker of tobacco, a moderate drinker, which I did consider, and also got benefit from prior cannabis use. And those are important things to tease out in the history, and we'll go through that here in a minute. And symptoms prior, he had significant bowel changes due to opiate, load. He had a difficulty in stooling every day. He had abdominal pain, likely from adhesions, and he had frequent hospitalizations for diverticulitis and obstruction because of his medication regimen. And his pain was very significant. So he noted a 9 out of 10 pain. His current medications were esomeprazole for reflux, endone, and stool softeners and laxatives. He had also used in the past Panadine Forte, Tramadol, and a buprenorphine patch. His kidney and liver function remained normal. His previous treatments there, he insufficiently treated. He had unwanted side effects. So we started him off on a 20 and 5 oil, initially dose of 0.25, and titrated it up. He got great benefit from 0.5 or 1.5 mil total of the 20 and 5, but he still had some significant acute pain. So he started to use less of his endone. He had much easier defecation, but he still had, like I stated, significant breakthrough pain. So we decided to use flower in that instance, and he had great benefit from that. Again, you can see the THC concentration in one axis and the hours on the next. So we started him off on a high THC flower. Very small doses were helpful for him. He started off with 0.1 grams as needed and never really had to go above that. And he was much happier chappy. His pain levels decreased from 9 out of 10 to 10 out of pain, generally with both forms of cannabis. His blood pressure decreased, and he hadn't had a bout of diverticulitis in about 7 months since starting cannabis. So that's a real success. No changes in his LFTs and his EGFR. So really our conclusion is split treatment with him was successful, worked very well. He decreased his opiates significantly, improved his pain, and he got back to work. So things to consider when talking to your patients and considering treatment with medicinal cannabis, had they had any prior cannabis use? And the reason that's helpful is, that your endocannabinoid system is going to be primed. Those receptors have already had cannabinoids occupying them. And so patients are going to be less sensitive and much different than those that are cannabis naive. Now, the endocannabinoid system can be really can be augmented very well in these patients. And we always have to consider what's going through the P450 system, how much alcohol they're having, if they have liver derangement already, any kind of pathology there. We're always considering method of delivery. We start with oil first. We consider ratios. There's such a variation in what can help patients. There's no hard and fast. different ratios can affect different people. One patient with neuropathic pain may actually respond to CBD oil very well and not so much with THC. So really what I tend to do is start off conservatively. There's no harm in that, and work my way up. Something to learn about is cultivars, or what strains that these medicines are made from, because that has a great effect. Some strains may be more effective for anxiety, some others may be better for pain. So another thing to consider is these terpene profiles. There is a great therapeutic benefit in having a robust terpene profile rather than having a skinny, very small percentage of terpenes. You get for instance, a flower that is a 31% THC may not be as effective as a 19% flower with a robust terpene profile. So get to know those, get to know your products, and get to know what's effective for each indication. And one thing that I always do is counsel my patients on drug driving, just as Dr. Phil did. It's very important to consider that, patients on the road and also getting drug tested. So always something that I can touch base with my patients about, always talking to them about that and addressing expectations. Key messages: treatment with medicinal cannabis is not about curing conditions. We're treating generally big picture quality of life, and we're treating symptoms and improving those. And the great potential for one medication to treat multiple systems, multiple indications is great, and therefore reducing polypharmacy. And for me, that's the greatest value of medicinal cannabis, because from a harm and a risk reduction standpoint, there's a no-brainer. I mean, you look at opiates, benzodiazepines, as Barb previously touched on, those, the toxicity and dependency is much greater than medicinal cannabis. So be bold, give it a go. Your patients definitely deserve it. So in summary, medicinal cannabis has a role in certain pain conditions and for certain patients. It's not, effective for some. It's not snake oil, but it definitely is worth trying. It has an excellent safety profile, is generally well tolerated. Efficacy varies like every other medication. So just as long as your patients know expectations and know that, then there's no worries. TGI applications are done through the SASB protocol and the APE protocol. They're much easier these days. I can probably finish a SASB in about a minute. So that's great to know, because at first medicinal cannabis was a bit daunting to get for our patients, and the time that we spent on those applications was quite significant. But for you guys now, I don't think it's an issue. It's a really great thing. So this is a rapidly evolving field. It's exciting. It's extremely motivating for me. And honestly, medicinal cannabis has been the greatest single medication that I've used in my practice in, almost 20 years of practice in medicine. Not a very long time compared to Dr. Finch, but it is an amazing little medication. And hopefully that this has been beneficial for you guys to consider adapting your practice and having an extra tool in your toolkit. There's lots of support, lots of training, lots of resources online, and I myself am happy to help too. I can be reached at my website, modehealthcare.com.au. You can always email me, and be happy to give you that. So thanks so much.
Thanks, Matty. I'm just going to see if I can click to the next slide. All right. Now, we'll do a little bit of Q&A between the both of you. Matty, you mentioned it briefly in terms of how medical cannabis, how has it changed your approach to treating chronic pain in general?
Well, I it's given me an extra tool in my toolbox. I mean, I think, we're not able to access it as a first-line treatment, but, hopefully we can. And I think, it's changed. It's moved up the line in my management tools. I think, once I try one of the first-line therapies according to guidelines, I quickly move on to medicinal cannabis if it's appropriate. So it's added another thing for my patients to potentially get some benefit.
What about you, Phil?
Well, I changed from being an interventionalist back about 5-6 years ago, and really it's been a wonderful change in my career of pain medicine. It's remarkably effective, and I continue to be amazed at the results. So I look forward to some hard data emerging, as it inevitably will.
Great. And Phil, when do you wean patients that you started on medical cannabis off of other pain medications? Is there a certain order?
No, I don't. I usually start the medicinal cannabis, and then later on, if they're feeling a bit better and more comfortable and getting some symptom control, start weaning the opioids. Often patients wean their own opioids, and you don't have to amputate their opioids and then start the cannabis. You won't succeed, but this way around it works very well. And there are other drugs too that you try. Some patients come along on an enormous number of different medications because they've been difficult to treat over the years, and they're on anticonvulsants. Pregabalin causes immense cognitive issues in lots of patients, and I found that the cannabis is much more helpful for them.
What about you, Matty?
Yeah, I agree. I mean, I start patients off slowly, getting them up to their effective dose before I titrate any medications, or titrate off or decrease opiates or benzodiazepines. I think it's cruel to ask them to do the opposite. I think it's much better tolerated with the help of THC sometimes with opiates to get them off. And Phil's study has proven that. And there are many other practitioners that are doing the same thing all over the world. The data is compiling how cannabis can help patients get off opioids in a very safe way.
And is there a certain order, like if they're on multiple medications, is it opioids you typically take off first, or pregabalin, or does it depend on the patient?
Well, some of them come back for review very proud. They say,
They do.
I've got rid of my Lyrica, and I've halved my oxycodone, and they're very proud of it, and it's wonderful, and it's wonderful achievement, and I congratulate them. And so I don't have a specific order. But, I'm sometimes alarmed by the number of other drugs they're on. And remember, the cannabis doesn't suppress their respiration, so you haven't got any worries about adding that into someone on opioids. It won't make them more respiratory depression. They'll have it from the opioid, but not from the cannabinoid.
A little tip that I do, typically, I'll give myself a little bit of room THC wise at the end. Okay, so for instance, I'll put a patient on a balanced full spectrum oil, okay, at 3 mils, which is under the maximum, and giving myself 10 milligrams of THC to add in case, you know, they need that extra THC to come off of the opiates. And I found that to be extremely effective.
Oh, that's great. And what about if treatment's not successful? I guess there's kind of, that's a two-pronged question. How do you know if it's not successful? And then or what if they decide it's not successful?
Well, you're following them up every now and then. So I start at the two-week spot after they've started, and then I usually expand it to a month, and then even longer if it goes well. So if it's not working, well, accept that and look at other means of treatment. That's the advantage in the pain medicine approach. There are other forms of treatment that my colleagues use very successfully, and you can turn to some of those as well. Thank you.
And Matty, what about you?
Yeah, look, I mean, I think if one ratio isn't successful, then I move on to a different one. I can move on to, you know, different companies potentially with other profiles, with other terpenes. You know, so there's lots of choices. Every week there's new products available online, and that, you know, is only for the benefit of our patients. So, you know, I'm a bulldog, really. I'm really advocating for my patients to try to get, you know, benefit from this type of medicine. And so I'm often, I'm unwilling to give up, really, unless, you know, of course I'm pointed by them. And I do let my patients point point me and help me make those decisions together, because the therapeutic relationship is a very important one to share, that responsibility.
Sure. And in the case of a patient wanting to stop, what's the process you follow? Are there withdrawal symptoms associated with that? What are the steps you take, Matty?
Gosh, no, there's no withdrawal with cannabis whatsoever. Patients can stop it immediately without any side effects, and that's much different than some of those other first-line therapies.
What about, you?
I agree with that. And one or two patients actually take cannabinoids on a PRN basis. It seems to work quite well too. Theoretically, if you stop, say, and you're on 30 or 40 milligrams of THC a day, and you stop it and have a week off and then go back on it, you might have adverse effects. But surprisingly, some people quite successful on a PRN basis. And on the earlier thing about if treatment is not successful, I really didn't cover the fact that, I'm assuming that all means of all types of cannabinoid have been tried or considered. And then if things aren't successful, then, well, you move on to other treatments, because it happens. It's life.
And what, from the patients that you find get side effects from cannabis, what do you feel are the most common, Phil?
Sedation, slight cognitive effects. Often these, if they're mild, settle down quite quickly in the days after starting. And occasionally you get surprises. There's a sore, dry throat is very common. What else? Sedation's the main.
Yeah, sedation, dizziness, dry mouth. I have had some, bowel movement changes. Sometimes that's due to the carrier oils, but for the most part, it's. Sorry, Phil.
One or two that have been had vomiting or severe nausea, and they've changed the base oil, and you can improve matters.
True.
So if cost is an issue, how do you manage it? Well, you ask the company producing it to please reduce their prices. Actually, my cancer patients get it quite cheap. Thank you, Little Green Farmers. So yes.
How do you deal with, so sorry, just to give that question context, there are compassionate access programs available from another number of companies. So Little Green Pharma have a 50% off program for our patients. Upon special request, we can give product away at no cost. And we also have a 10% discount for concession card holders. So there's a number of different avenues there. From our perspective, from a Little Green Pharma perspective, we don't want cost to be a barrier to someone trying it to see if it's going to be successful. And there's obviously some patients who have an ongoing issue with cost, so there's different tiers to be able to cope with that. But I guess taking that aside, if how else do you manage that? Is it a ratio thing with patients? Is it introducing flower? Are there any other ways that you found that you help patients manage that cost?
Well, sometimes, say they're on a high amount of LGB 1010, that's the balanced cannabinoid. You can go to the LGB 20 to 5, that's twice the THC, and but it's much the same cost for volume, and they're getting, you can halve the amount that patients have to take for the same effect. So that's one thing you do. One or two, compassionate supply for the for cancer. They get it free or very reduced price. So I say thank you, Little Green Farmer.
You're welcome.
So a couple other things too, guys. Lots of insurance companies are now rebating. That's another way to to reduce cost. That's a huge one. You know, it started out with one, and you know, now it's the domino effect because you know patients are demanding that, and that's a great thing. The second is research studies. Those are happening all across Australia. That's a very good way to reduce costs because some of these companies that are involved can give patients study medication.
Yeah, good point. I'll touch briefly on the driving issue because you both have managed it. But I guess what's your key takeaway in terms of driving, Matty? How do you with patients?
Oh, look, I mean, there's a no tolerance policy. Unfortunately, you know, even if patients are using their medication the night before appropriately, they can still get in trouble the next day. So, you know, we really reduce that risk by just using CBD during the day, having our patients, family members or friends drive them, and also waiting to use their medicine until they get to their destination or after they've run their errands. That's really how we mitigate that.
So I definitely counsel all patients and get them to sign something so that they absolutely understand that document that I showed you earlier on, that it's a quite legal drug, but it is illegal in almost all states except Tasmania, I think, to have a trace of THC. And you can pick up traces of THC days or weeks later, depending on your equipment. So some patients get spouses to drive them and they get around this. But my advice is be very careful and don't drive.
Sure.
Yeah. And just to give again that question some context there, there are a number of campaigns. Drive Change is one of the national campaigns where we are actively lobbying, you know, politicians to look at amending those laws, because medical cannabis is one of the only, or is the only prescription medication where you can be prescribed it, but you're not allowed to drive, regardless of your level of impairment or perceived impairment. So that's more a change that happened. You know, they legalized cannabis, but they didn't think about the driving, so it just hasn't really caught up.
So really, it should be like alcohol, and it should be based on a blood level, which will be in nanograms per mil, and rather like Canada. I think Canada's got a system, and also impairment, the degree of impairment. So it's those two factors really should be considered. Hopefully one day this will change.
Yeah, no, I think it will. Now we've got quite a few Q&A, so we are a little bit over time, so I'll cherry pick some of the ones we haven't covered. One of the questions is around flower prescribing. The TGA recommend the max prescribed amount of 1 gram a day. This is from a nurse practitioner. She sees other doctors prescribing much higher amounts. What are your thoughts on that? Maybe to you, Matty.
Yeah, one gram a day is sufficient. I think it's an opportunity to help patients, you know, changing from the recreational market and using their flower appropriately. I don't see the use of flower above 1 gram. I don't think there's much data in it, honestly. So I take that as an opportunity for patients to reduce and use it appropriately.
Yeah, thank you. Phil, are there any pathological investigations that are required or that you do prior to starting a patient on cannabis?
If they got issues, heart issues, quite often, I write to the cardiologist and ask, do they have any objections? In all the patients that I've seen one person get a significant tachycardia and have to stop it. As far as psychotic reactions, I've only seen one person who had some mild psychosis in the past. I probably shouldn't have prescribed it, but she developed a mild psychotic reaction, and as soon as she stopped taking it, she settled. So those really the only two. Occasionally, if people have problems with their liver function, I get that estimated LFTs estimated. Again, I've never seen cannabis, the introduction of cannabis to greatly alter liver function tests. In fact, often they improve because these patients get off their opioids.
What about you, Matty? Is there a certain diagnostic?
Yeah, look, I think liver and kidney function is important. I mean, I always do those and then repeat them just to make sure that we're not, causing any issues. I haven't found any, to be honest. I was much more diligent in doing that at first. Sometimes, admittedly, I lax on, the 2 week and 4 weeks. Sometimes I'll just do 4 weeks, and if that's okay, then I don't continue to follow that.
Well, and that's all really important, isn't it? Because those are your learnings throughout it. At the beginning, you're a bit more nervous and cautious, but yeah, once they're comfortable. Another question is about your experience using medical cannabis in end-of-life care.
Yes, I'm interested in that. I see a number of patients with advanced cancer.
Mm-hmm.
It's accepted well by patients, and I work with one particular oncology group in Perth, and it's really been quite helpful to a lot of people. So I think it's one of the prime ways of treating their symptoms. Helps their nausea from chemotherapy, and it's a reasonable pain analgesic agent. So it's been very useful, and I like this work. I think we owe it to these people.
Yeah, I agree. It's extremely meaningful. I've been working with not only some palliative care docs as well as the cancer group here in the Southwest, and they're very open-minded. We correspond back and forth, and we've had some great results. And the more open and accepting they are of it, the more they're surprised how well it works and how it helps patients end of life, and that's the most important thing.
I'm prepared to push the THC component up quite high, a lot higher, over 100 milligrams a day or more. I think that's fine in that group.
For sure.
And are there particular symptoms that you find it helps more with, like the anxiety or the pain, or is it just a more holistic effect in that cohort?
For cancer
end of life,
patients, well, often they've got chemotherapy symptoms such as nausea, vomiting, peripheral neuropathy symptoms, neuropathic symptoms. It helps those two groups, and it's
and cachexia too, right, Phil?
Sorry.
In the cachexia, the body wasting.
Yes, yes, well, their appetite a bit. So it's a very useful agent in that group of people.
Oh, that's great, thank you. One of the questions was around, again, coming back to the flower and the max dose. So do you change your max dose, Matty, when you're, depending on the percentage of the flower? So this question is around the max dose, for example, at 20% flower, would you go higher on the grams, or would you still stick to 1 gram a day, or might you go up to 1.5 grams?
Gosh, guys, I don't really know if that's effective or not. Like I don't adjust. Yeah, I titrate it up slowly, starting at 0.1 grams and work my way up, and then follow them up closely. It's a Schedule 8. I think that's important, that patients can have the opportunity to ask questions, make sure that they're doing things appropriately, and reducing tolerance and abuse potential with close follow-up is really important.
Yeah,
I've been a little bit reluctant to prescribe flower, and very seldom do, but I think in the cancer group, it's very useful. They can have they can vaporize cannabis for acute exacerbations. I think it should be considered there.
And a patient cohort that I'm extremely passionate about is our veterans, and most have chronic pain and PTSD, and so that chronic, those two indications are treated really by the same medication and same ratios. I found that flower can be really helpful in those folks with panic and helping them get to sleep, because that fear at the end of the day prevents them from going to sleep, staying asleep. The nightmares are awful. And THC and the fear extinction model has been extremely helpful in those patients. So I'm not afraid to use flower on top of oil in those guys and girls.
That's great. That's actually really interesting. Thank you.
Mm-hmm.
Now that's kind of it from the clinical questions. There was one last question around how a pharmacist can refer patients to LGP's concession discount. They can just request it at that concession rate, as long as they've cited the card. So that's fairly easy to do. And that concession discount is available through Oxford Compounding. That's one of our 3 distributors, but we run that through that particular distributor. All right, well, we haven't done too bad. We're only 10 minutes over. I'll take this opportunity.
Not my fault.
No, it's actually my fault. So I apologize that I rushed Phil. So apologies. I take full responsibility for that. We do have a national MSL team, so we'll send these slides out tomorrow. But yeah, just want to take this time to say, Phil, Matty, thank you so much. It's been fun. It's been interesting.
Pleasure to help.
And yeah, I hope everyone who's joined in, thank you for taking time out of your busy evenings to join us. And yeah, we appreciate you taking the time, and we'll send out a wrap tomorrow. Awesome.
Cheers.
Thanks, guys. See you later.
Bye-bye.
Bye, Maddie.
See you, Phil.